Hello, I'm Robert McMullen, and I'm a psychiatrist that specialized in treating depression and other psychiatric illnesses, treating them mainly with medication. And for psychotherapy for depression, I refer people to specialists in that area. And for the last 6 years, I've added TMS, transcranial magnetic stimulation, as a different modality for those people that have failed on the medicines. Now, people are asking, what is treatment-resistant depression, and how bad is it, and what causes it? Well, there's different definitions of treatment-resistant depression, but it's basically depression that's been adequately treated by 3 or more medications, 3 or more antidepressants in adequate doses for at least 6 weeks, and that they've had very little response, and certainly have not come into remission. And we count as a response in research to have a 50% improvement. And it's not, usually the people that we call treatment resistant don't reach that. They may improve, but their scores don't come down over 50%. Now, the causes of it are just the possibility, just like some people have a worse case of diabetes, or some people have a worse case of arthritis. It could just be bad luck. It's sometimes there's no explanation, but it should be looked into as to your thyroid level. Sometimes having even a slightly low thyroid indicates that if you add some thyroid hormone, the brand name of which is Cytomel, that may help the depression. And you should check the B12 and a few other things. One thing that's becoming more important is checking the inflammation level in the body. And this is best checked by the HS-CRP. HS is for highly sensitive, and CRP is for C-reactive protein. And this measures the inflammatory hormones that are floating around in your bloodstream. And these go way up when you have an infection, and because they're there to alert the body to mobilize more white blood cells to fight off the infection. Or if there's a cut somewhere in your body, then these hormones go up in order to attract white blood cells to that area to repair the damage. Well, it so happens that this high CRP is associated with an increased rate of depression and an increased rate of heart attacks. The cardiologists are spending a lot more attention on this. If somebody's cholesterol's a little high, or even average, and they have a high CRP, then they are very motivated to put the person on a statin to reduce their risk of a heart attack. And similarly, when this CRP is high, it indicates that perhaps using some anti-inflammatory treatment might help. For example, using a lot of fish oil, being on an adequate amount of vitamin D, which is about 5,000 international units a day for an adult, and getting the vitamin D level up well above 40 or 50. And possibly using a statin. There's some studies showing that statins for cholesterol help depression, especially the ones that are more fat soluble, so that they get into the brain easily, which is simvastatin and another one called Crestor, which is rosuvastatin. And I haven't had so many people that had an immediate antidepressant effect with these. I think the effect happens slowly, but also it could be that when they come to me and I add a number of different things, that when they are getting better, I can't say it was the statin that did it. However, in the last year, I had a couple of people who reduced their statin. One person ran out of simvastatin and intended to pick it up on the weekend, and the other one reduced her Lipitor by half. And both of them suddenly went back into a severe major depression, which they were completely out of. And they were quite surprised. And when they restarted the statin, they came out of it. And there are some studies showing that these statins help depression. So I would be taking one even if it doesn't seem to have immediate benefit. Now there's other ways to decrease inflammation, and those other methods may also help. But if you use a lot of augmentation strategies, you use a good dose of an antidepressant that's working somewhat, and then you add other things in, like a tiny dose of lithium, maybe a different antidepressant like Wellbutrin, bupropion, and various nutritional augmenters, and you still don't come to 100%, then one should switch to TMS, or should add in TMS. I look upon it as an augmenter because people do much better if they stay on an antidepressant that's at least halfway working, and then we add the TMS to it. And a lot of the early studies on TMS seem to show people not having such a robust response that maybe 15% of people would come all the way to normal. There were a few problems with those studies. Is one, they took people off all their medications, so they started from zero, and they often only did 15 treatments when we now know people need about 30, and they often used a little lower intensity, and they used fewer pulses. Instead of using 4,000, they might have used 1,500. If you look at all the parameters, they are not as effective as the parameters we use now. And then one has to also remember that you have to have as a goal getting rid of the depression completely. And this should just be a goal in general, because who wants to go around for a few years being mildly depressed and dragging along? You should always be working for achieving complete remission. But there's a second reason, is if people have some residual symptoms of depression, that they still have a little bit abnormal sleep, their self-esteem is down a bit, their energy isn't that great, it's a little hard to concentrate. If they have residual symptoms, then they have a very high rate of having a relapse in the next year into another major depression, another big depression. Whereas if you get people all the way to normal, whether it's with medication or with medication and TMS, however it is that you do it, they have a much higher chance that they won't relapse into a big depression in the next year or two, but can maintain that euthymic, that normal state. And that's the goal.
Thank you very much, Dr.